so that's great. Thank you so much. I thank the organizers for the invitation. I think for the challenge. That's why I was late, because I learned that I don't know anything about the topic. I know a little bit more now, and I will share what I learned. And I hope this will be inspiring, and especially for the discussion afterwards. These are my disclosures, and as I mentioned at the bottom, I'm not an expert. I did realize, and I think many of us do know, prevention is the main goal we have to achieve in regard to malignancy in the context of inborn errors of immunity. Treatment is, for many of the malignancies, very hard and probably late. So we need to be better in preventing by screening and by doing the right things of reducing risk for developing. So the outline of my talk is here. I will start with one case report of our patients. I will give an overview of malignancy in inborn errors of immunity. We'll briefly discuss with you pathogenesis of common risks for immunodeficiency as well as malignancy in these patients. I will discuss then subsequently special risks in special inborn errors of immunity, and then discuss, hopefully with you, in a lively discussion afterwards, what we need to do in the near future. This is the case report, and this is a patient, male patient, with a complicated form of common variable immunodeficiency. He was born in 1970, diagnosed in 1997. He fulfilled all the AZ registry criteria at that time. He had the classic phenotype of a complicated CVID patient with, at that time, not strongly reduced B cells, low switched memory B cells, and expansion of activated 21 low B cells. He had, at that time, still borderline normal naive, but developed quickly low numbers of naive CD4 cells. And later on, you can see that he dropped his CD4 counts to below 200. And I put them in blue because I do think these are signs of risk factors for complications, including malignancy in our patients, and I think we need to learn more to recognize them early. The infection profile was in many ways classic, with upper respiratory tract infections, which are recurrent. He had, however, also signs of a T-cell immunodeficiency in regard to that he reactivated 3 times zoster, and he had an anal HPV infection, which was not due to an HIV infection, and he was chronically norovirus positive. So he had clearly viral control problem. Again, another sign of a risk for secondary problems, including malignancy in our patients. The secondary complications at that time was until 2006, and then he was cured and in full remission of an anal carcinoma in situ. He had autoimmune cytopenias, he had enteropathy, he had hepatopathy. So again, severe complications of this disease, as most of you will know. He had then in the genetic diagnosis, and again, I put it in blue because I think genes play a role in this risk, and NF-κB1 is one of these genes in my eyes. We couldn't quite prove the relevance of this missense mutation, but we think that it might be involved in his partly combined immunodeficiency as well as the risk of the subsequent cause of the disease. He was treated, and again, I should have put it in blue, I forgot, I'm sorry, immunosuppression. So he received for his complications immunosuppression, increasing his risk of malignancy, as we know from transplant patients and others, that this will increase the risk. And it was many times discussed with him whether he would consider stem cell transplantation for his disease, but he refused. And I don't know whether it would have helped him and prevented the further cause, which was then a liver metastasis, which we could not quite find the primary tumor and he died in 2021. The questions which this raised, and these are the questions for our talk, our discussion right now and my talk, is what are the needs for more vigorous screening in these patients, and do we have good parameters to decide whether these patients do require stem cell transplantation preemptively to prevent malignancy to happen. I will jump over this because I understand that somebody will talk after me about lymphoproliferation. But again, it is a case of lymphoproliferation, and it is important, very important to do genetics. And I will only touch on that. In this case, it was a patient who was diagnosed with lupus, but had low immunoglobulins, was then subsequently genetically diagnosed as an APDS with an activated PI3 kinase delta syndrome. And unfortunately, when we made the diagnosis, and we felt very smart about this, telling the parents and her that the best thing she can do probably after having developed the first lymphoma to transplant. She died during the transplant, and we felt terrible because the patient had traveled 800 kilometers to come to us to be cured from her disease, and the parents had to take back a dead body. So again, I think it just shows how challenging it is to be in such a situation, and ideally we do such things outside of these complications and don't face secondary complications. Now, my general thoughts on risk factors for malignancy are known to you, and I hope that most of you, and that's why I felt embarrassed to present this here, have seen the grand rounds of the ISIT 2 weeks ago, which had exactly this topic. And I have to say already now that Markus Seidel helped me a little bit in the preparation by providing some of the slides in areas where I'm not so familiar with. So what is clear? That there are obviously risk factors which are directly affecting the risk of tumors, and this is the acquisition of activating mutations in oncogenes. It is also the deleterious mutations in tumor suppressor genes. And there is a disturbed DNA repair as a general risk factor for malignancy in our patients. So this is, I think, has already proven by the many malignant problems in these patients. Now, the more tricky part, however, the association clearly hints toward it is that reduced immunosurveillance is a problem, and this is especially true for virally induced malignancies. But it is also the immune dysregulation, which is associated with constant activation, with inflammation, which drives risk of tumor development in these patients. There's a lack of control of the viruses, which is overlapping with the previous argument I gave, especially with EBV and HPV in our patients. And there's altered cell differentiation, and there drivers of increased proliferation in some of the especially lymphoma-associated malignancies in our patients. So this is the first slide, is that relevant? Yes, it is, because we do have a clearly increased risk for secondary malignancies in our inborn areas of immunity. They are cell intrinsic and they are cell extrinsic, as I just mentioned. And the outcome of the malignancies is worse, and I think I will quote some of the papers, partly coming here from Italy as well, is this. And this is just one of the examples, and Isabella is here in the audience, and it just shows that if you have cancer with CVID, the outcome is worse, and we just can confirm this from many different cohorts, including our one in Freiburg. So what are the differences? So there are increased risks for certain malignancies, and the malignancies present often earlier than they would do in the normal population. Here's one example from the ESIT, and here's another example from the USIDNet showing the same thing. There is an increased risk for certain types of tumors, and the risk presents early. There are different ways of moving into malignancy, and here are just shown some which I just already mentioned. And I think, let me see what I can. Does this work? Probably, right? Yeah, perfect. So there is obviously the risk, as I just mentioned already, of the DNA double-strand breaks or DNA repair defects. That's clearly. I mentioned already EBV-driven lymphomas, and this is mostly lymphomas, not excludingly, with many immunodeficiencies which have a loss of control of EBV. There is decreased control of lymphoproliferation in fast-mediated, but also downstream of fat has been shown now, and others which clearly show that apoptosis is a major regulating factor for preventing malignancy in some of our patients. There are, and this number is increasing, activating mutations in PI3 kinase delta. I mentioned CARD11 in the Benta patients are some which again drive diseases in the lymphatic cells in themselves, mostly B cells. There is, and this is the part which is more tricky to show, but I do think it plays a major role in it, is that we have chronic inflammation. There is a dysregulation of the immune system, which then will lead secondary to a higher risk of cancers in these patients, and these are not restricted to the hematopoietic cell line. And then there are other factors, especially if they can't control HPV associated with a higher risk of HPV-related carcinoma in these patients. This is a slide which Fabian Haug, together with Markus Seidel, prepared for this review in 2018, trying to go into now that not every immunodeficiency has every risk factor for developing malignancies. And you see here all at once the different factors influencing it. So what you see, and I will start here with the first one, that you have obviously diseases like GATA2 is the one most familiar to me, where it is basically already a dysregulation in the bone marrow, which goes not only hand in hand with an increased risk of MDS, but also secondary AML in these patients. You do have problems where you have a higher risk of lymphoma. This is especially in the patients with CVID, but others. Some of them are driven by the mutations. Some of them, they're without mutations, still carrying the increased risk of lymphoma in these patients. This is lymphocyte signaling. Here would be APDS, here would be Benta, as already mentioned in this, which changes this, but Wiskott-Aldrich with cytoskeleton-associated defect as well. We have chromosome stability, telomere maintenance, which is obviously an important driver, especially of hematopoietic malignancies, but not only, and also in others. You have the transforming viral, and here are some of the examples for the HPV associated. You have an increased tissue inflammation, as I mentioned, with including patients with immune dysregulation, and you have the impaired immunosurveillance of these viruses, as mentioned already, just outlined in a graphic form by Fabian and by Markus. Now, this is just, and I don't go more into lymphoproliferative diseases, but there are clearly associations, and this is shown with Roshini Abraham has put this review together, just going through all the records, which has what has been published as a systematic review. And what you can see here, that there are some diseases, and I just highlighted them because they are disproportionately high with the risk of developing lymphoma in these cases, like XLP, APDS. Interesting IL-10 receptor deficiency, I will not touch on more, but it's incredibly high for the number of known patients with IL-10 receptor deficiency. ADA deficiency, again, unusually high for a low number of patients over Nijmegen breakage syndrome. There, the astonishing thing, and shows that there's a different driver than in the others. You have a lot of T-cell lymphomas, while all the others almost exclusively or mostly B-cell lymphomas, except for agamaglobulinemia, because you don't have B cells there, and they are mostly T cells. Now, going into the specific immunodeficiencies, here, the Nijmegen breakage syndrome, and what it shows here, basically, that you do have this clearly increased risk of these patients. They are mostly hematopoietic, as I mentioned, but not exclusively. And you see the history of malignancy clearly impacts strongly on the survival of these. And the Nijmegen breakage recommendation for surveying these patients is definitely that you have regular physical exam, blood counts, that you do, and this is now not totally agreed on, that you definitely do imaging because you want to discover early. The form of imaging in the Nijmegen breakage where you should definitely avoid radiation is either ultrasound as a more regular screening method, but typically including also MRI, and we have one patient in our adult cohort where we do perform now annual MRI screens to really do a whole body scan for this. And the question which was raised in another work shown here by Wolfgang Kusniewicz as the first authors was the question is, do we have a reason for preemptive stem cell transplantation? And I think the answer is not given yet. How? Because stem cell transplantation in these patients is complicated because you have an increased risk of developing malignancy, obviously due to the radiosensitivity in these patients. However, this is at least putting out the thought that we need to think about it, and the conclusion might be patients who have developed one cancer should not develop a second cancer, and stem cell transplantation should be considered in these patients with Nijmegen breakage syndrome. This is not true for this, obviously, immunodeficiency, which you also know, atalaxia, telangiectasia, due to ATM mutations. Here, the outcome of the transplantation is overall so poor that this is not considered a general recommendation for these patients. And you can see here the development of malignancy, that they don't all develop at the same time. Here you see the risk, and at the end, it's about 40% of these patients do have malignancies. Most of them, again, are of the hematopoietic cell lineage, not all. But you see the curve of with and without cancer. They are both not very positive. And so therefore, it needs to be regarded differently compared to the knee-making breakage syndrome. But again, obviously, there's a strong need of thinking about how to help patients with DNA repair defects. Now I finally am allowed to come to the disease which I know best, which is common variant immunodeficiency, as most of you know, and this is what we are mostly concerned in adults. So there is a systematic review done by the Iranian colleagues, and they show that there's an overall prevalence of malignancy of 8.6%, and the ones sticking out is lymphoma, gastric cancer, with 4.1 and 1.5% of the CVID population when they do all the reported cancers in the literature. And they also had a 1.3 of breast cancer, where we personally don't see a signal in our cohort that this is increased compared to the general cohort. They say autoimmunity and malabsorption more frequent in patients with malignancy. Now, this is the paper you all should know, and I'm sure you all do know. This is a paper clearly showing again that there are certain type of cancers more frequent in CVID patients. And this is clearly the non-Hodgkin lymphomas, and it is a gastric cancer. Now, there is a variation between the different areas of origin. So gastric cancer is much less, or it is less frequent, I should say, in Germany than it is in Italy. However, the relative risk of developing this cancer is the same for CVID. So we do see the same proportional increase of developing gastric cancer in Germany as we see, as you saw in Italy before. And it is not only an increased risk, which is true for both genders, but it's also an increased risk once you develop it to die from it compared to the general population. So the outcome is poor, and it is clear, and that is always true, the earlier and the less progressed the disease is, the better is the survival. There, I think, Isabella, you have to correct me, but I think it was only one where the staging was shown with stage 1, so I'm not quite sure how robust this curve is, but it clearly shows that there are staging plays a major role in this. And here you see that cancer plays a major role in survival of our patients, as Isabella had shown very, very nicely. So therefore, Isabella had very early on recommended that everyone should have a gastroscopy at the beginning to stage basically the risk factors of this, and that atrophic gastritis is a major risk factor. All of them had atrophic gastritis, and it is clearly the same in our cohort. So that means that you need a targeted surveillance strategy for these patients for sure, which says every year, and we do the same, every year they should have a gastroscopy. If they have already dysplasia, you do it even more frequently every 6 months. The reason for that is also given in that paper, that some of these patients progressed very quickly from low or even no changes to having malignancy, and therefore the observation is, in my hand, absolutely correct. The big debate is how you do the gastroscopies in patients who have nothing, no complaints, and so they are not very happy to have gastroscopies every 2 years. And this is a debate, and I'm not sure that we know already the answer how we can do this in this cohort. This is just from Patrick Betts, who put together the data for why do our patients die. And we looked at malignancy and tried to develop a risk score 5 years before they die so that we can hopefully stratify our patients better. Malignancy didn't play a role. Why did malignancy didn't play a role? Because they didn't survive 5 years. So the problem is here that, as you can see, that the gastric carcinoma were almost all dead, and only one was still in the control group. The second most frequent, interestingly, in our cohort was cholangiocarcinoma with much higher, I mean, there's only 2 patients, so we can't say really what frequencies mean here. But if we need to really, really make clear what are the major carcinomas in our patients, with gastric carcinoma being clarified already, and then we need to see whether other observational and surveillance strategies are needed in our hands. The other one is lymphoma, and I think it will be discussed right after me in regard to what you need to look at. Yes, we do agree that autoimmune cytopenia and enteropathy are two major risk factors for this also in our cohort. And now just last year, and I don't know who saw it already, a Spanish study came out looking at the Spanish cohort and basically find again similar distribution of the cancers. And they tried to identify risk factors, and they saw that the risk factors which they could identify was previous immunosuppressant treatment, signs of immune dysregulation, obviously going hand in hand. So it's, but they were independent risk factors. Age plays a role, which shows again that we need to stratify our surveillance also according to the age of our patients, obviously. The last follow-up of IgM levels, saying that positive IgM levels have a higher risk of developing lymphoma, and CD4 cell count at diagnosis. If we do that for our patient and use the score they suggested, so they developed a score predicting the risk of malignancy in our patients, and the score has to be read this way, that you basically look at these 4 categories, which they said are clearly associated with. Then you say, okay, my patient had immunosuppressant, then you get 90 points of that score. If you have immune dysregulation, you get, again, 90 points. If you have IgM levels at this whatever level, then you get according points. Cell phone counts, age, you get counts, and then you develop, add all these risks, and get a total score, and the total score, they correlated with the probability of malignancy in this patient. I think this needs to be verified in a larger cohort. If you do that for our patient I showed you in the beginning who died afterwards, he would have had 350, which is here, and a probability of malignancy of 0.6, which is obviously high, but I think we have quite a few patients who score high on that score and have not at least a detectable malignancy at this time. So I think this needs to be revisited, but I think that's how we need to think, and that's how we need to work, and that's how we need to collaborate to have really good data, to really tell our patients, you need to be scored and you need to be really surveyed by gastroscopy or whatever the survey is because of that probability of malignancy. Now coming to the different ones, ALPS, APDS and others with driver either of intrinsic proliferation or of control of proliferation mainly develop lymphomas, and therefore I will not discuss further. The loss of EBV control, again, is mainly lymphomas. I will not discuss further because they will all be of the next talk. CARMEL-2 is the one exception of loss of EBV control, where you have additionally smooth muscle tumors. And here the recommendation screening is by MRI, full body, because this small muscle tumor can sit almost anywhere in your body, and so you can't predict, and it's very high to find otherwise. Immune dysregulation can drive it. What you see here for CTLA-4 deficiency as one example is basically just stating you what we know in general from CVID, basically that you have immune dysregulation, you have inflammation, you have an increased risk of lymphoma, you have an increased risk of gastric carcinoma in context of autoimmunity and atrophic gastritis, and the rest is possibly EBV related. One thing which I would highlight now also is GATA2 deficiency. GATA2 deficiency is a disease which either are seen by hematologists or by us because they have such a high risk of hematopoietic problems. In this case, not lymphoma so much, but more of bone marrow, again with development of an MDS and AML as a secondary component, but they do have additionally risks for HPV-related cancers, and this is work from the NIH and with Steve Holland in the group, showing that basically this needs to be surveyed very carefully, and perhaps, if we do see this already, again, indicate early stem cell transplantation as one of the solutions for this high risk of HPV-related cancer, especially in women compared to men. Now in the last, 1 minute, I would just like to discuss with you the need and would like to discuss hopefully literally with you because I think we need to discuss it. This is complex, and that's why we need multidisciplinary teams. That's what MDT stands for. That means you need your oncologist, you need your hematologist, you need whatever dermatologist, gynecologist, whoever surveys basically for these malignancies we are discussing here. We need guidelines, and I think that is a really urgent need so that we do it better and we do it the same way, and hopefully then can tell how we can still improve. And the guidelines need to include screening, they need to include how to diagnose and to treat. The registries, I will come back to in a second, and we need retro and prospective trials. And the idea is that we improve the diagnosis. Histopathology, huge problem. We had patients, they were diagnosed after discussing back and forth between the different pathologists for half a year. They were then diagnosed with lymphoma. We had to treat them with steroids because of other complications. Patients survived 10 years, never had a lymphoma. That just shows how difficult the histological diagnosis is. So, and again, here we need the pathologist to find better ways of diagnosing. We need, including stem cell transplantation, as I discussed already just a second ago, we need to find out who is the one who needs preemptive stem cell transplantation, and if we have especially radiosensitive disorders, then we need to discuss how are they transplanted the best way and who should be transplanted, who not. To do all this, yes, we do need a better understanding of pathogenesis and overlapping pathogenesis and how we can influence and how we can reduce risk factors. And therapies will be the one. Here, and this is again a slide I borrowed from Marco Seidel, because there's an ongoing survey right now of the current ACID registry data, trying to understand which malignancies appear in which disease. And this is ongoing. He's building it up right now. I hope that we will see the results by the end of this year. I need to wait for Marcus on this. This is a slide I took from a review from Fabian Haug with Sarah Bartmettler as the first author. Thinking about how can we improve that. And I think that is challenging. And yesterday I had a discussion with Francesco about diagnostics and pathology. I think the tumor itself will be one of the crucial insights. So lymphomas, for example, will be one of the crucial insights of, we know the underlying, or in many patients, we know the underlying genomic mutation. But we can now specifically investigate the additional somatic mutations in these patients, seeing how the genomic mutation basically sets a basis for additional hits, which then drives it into tumor genesis. And this is not only interesting for our field, this will be interesting far beyond that, because I think it will tell us more about lymphoma genesis in general. And I think this is something where we can really invest much, much more in the future. So, yes, malignancy is a prominent challenge in inborn errors of immunity. Prevention is the key, and I think, for our patients. So we need to be better screening, but they should include age, the specific inborn error of immunity, and additional risk factors, and to develop programs. We need to identify and control risk factors for malignant transformation. Some of them are listed here, which are the easy ones. There are many more, and they need to be discovered and clearly described. Diagnostics, we need improved diagnostics. As mentioned, the histology, for example, in the lymph nodes. We need, and this is something which I really can encourage you at each center where you work, try to develop colleagues, and together with colleagues from other disciplines, such MDTs, to really take good care of your patients early enough and not afterwards say, oops, we missed that. And therapy, identifying potentially specific needs in patients with inborn errors. So we need to be careful that not everything can be transferred one-to-one from what oncologists do with other patients. And as I mentioned, we need to define the role of preemptive stem cell transplantation in our cohort. And with this, I would love you to all support registries, prospective and retrospective clinical trials, which we just heard about some of the studies, which is essential for the field. And with this, I want to thank you for your attention. I need to thank my group in Freiburg. I need to give a very special thank to Marco Seidel, who helped me getting a little bit closer to the topic of what I was asked to do, and I hope we can have some discussion now. Thank you very much.
Thank you, Klaus, for this complete overview of the cancer susceptibility. The speech is open for discussion. There are questions. Sandro Urbani.
I can repeat the question.
Thank you, Klaus. And then to have a clear idea of the real incidence, of the frequency of tumors in common variable immune deficiency, don't you think that we should classify patients with common variable immune deficiency according to the genetic defects? Unless, because many of the paper you have cited, in these cases, common variable immune deficiency was based only on the immunophenotype, so which does not respect really, the risk to develop tumors in different subset of patients with common variable immune deficiency.
Thank you, Sandro. I agree and I disagree. So I agree absolutely with you that we need the genetic information. However, the lymphoma risk of our undefined, genetically undefined, despite exome sequencing, genome sequencing, undefined CVID patients is not much different from others. So I think there's clearly an immunological driver without the genetic background we can identify at this time. I think we need it. I totally agree with you. There are probably some less frequently associated with malignancy, some are more. But what I'm trying to tell is that especially the patients where we don't find genetic, they are sometimes the worst and they have the same risk of these malignancies. So I think genetics is an important part, but not all the question, not all the answer to the question, sorry.
Klaus, Maria.
A question about the therapy. We know that we need to give immunomodulation with the rituximab or many others therapy, but they have a risk for cancer, and you just put it in the risk factor for malignancy. Do we have data for understand which one of the immunomodulation is less? Thank you.
Excellent question. So the question is basically, do we have safer and less safe immunosuppression for our patients? And to be honest, we don't know the answer yet. I always thought in regard to cancer that rituximab is fairly safe. I also always thought that rituximab also in regard to lymphoma is fairly safe because you kind of targeted that same population. And so the answer is open. I do think taking away T-cell control is a higher risk, and I think time is a high risk. So it will not only depend on the drug you're using, but how long you are using it. And I think that is what we need to think about early on when we consider whether we want to go into long-term immunosuppression, including JAK inhibition. JAK inhibition makes it so far and wide right now, and everyone is excited about it, and I am too. But we don't know what the 10-year risk of a patient under JAK inhibition for the tumors is. And therefore, we need to consider very early on when we put them on these regimes, which are obviously not needed at this time point, do we have a long-term concept? Is this what we want to do with a patient like ours? I mentioned, he was an MMF for 10 years, more than 10 years, and he developed this carcinoma. He had anal carcinoma in situ beforehand. So we need to consider that, and that I think needs to also make us think about what are the alternative, and is stem cell transplantation a long-term better alternative early on, rather than at the time point when we discover, oops, that was too late.
Klaus, excuse me, just one comment. A few years ago, we published with Genevieve San Basile and Vialmo's case a bizarre observation. We studied 8 patients with elevated levels of IgM without mutation in the genes underlying the hyper-IgM syndrome. And interesting, we found that in the follow-up, during the follow-up, half of these patients developed a lymphoproliferation. Why don't introduce in the score system, in the scoring, also the Ig levels before the transformation?
Yeah, and did I hear that correctly? There was the increase of IgM?
Yes.
You were supposed to, yeah, right. It was mentioned, and so I agree with you. So I think that is definitely one of the factors which might be worth putting in there, and it's a cheap one, and we have easily access to it. So I totally agree with you. I don't have the data from our cohort at this time to really see how well it works. But as you say, it is one piece. And if we can add these pieces together to really develop a meaningful risk score, totally agree. It's the cheapest suggestion I heard today.
Ella Quinti, please.
Oh, no.
Thanks, Klaus.
Prepared.
So, great talk. If I can summarize, we are in trouble. This is, I think, the summary of my question is, we were in trouble, we are in trouble now. So how much aggressive are you now in cancer surveillance, cancer control, treatment? So you think in your group, your way to manage patient is changing according, okay, we are waiting for whatever, risk factor, score, whatever. But in the meantime, you think we should be more aggressive? Because also patients suffer a lot. Because to make a cancer surveillance, not only one cancer, many cancer surveillance is a very tricky story. So is it changing your attitude?
Yeah, the answer is yes, and it has. So gastroscopy has become, despite the patient saying, oh, I don't have any complaints, shall I, has become part of it. So yes, it has. It has not yet for others, where we still need to learn. I think it's a huge challenge, lymphoproliferation, because most patients who develop lymphoma had lymphoproliferation beforehand, right? So we do not have a really good, except taking the lymph node out, and as I mentioned, even that is not necessarily 100%. So we don't have really good screening parameters there, so there's a lack of screening. In regard to skin and under immunosuppression, yes, we do. So we do recommend that they do go to preventative dermatological screening for this. In patients who are on immunosuppression with GATA2, it's obvious, or with other patients who have high risk for HPV-associated infections. But I think I'm far from feeling comfortable about the suggestions I make at this time. So I think I would definitely love, and I think that is a need, as you said. I don't like to call ourselves in trouble, because I think the world is so full of trouble, and I think sometimes it leads to paralysis, and I would just love that we say, yes, we have a challenge. I think that's what I learned from my coach. No, I'm kidding. But yes, we do have challenges, and we need to address them, and I totally agree with you. We are not there yet. I absolutely agree with you. Yeah.
Okay, thank you,
very
Klaus, very much.
E procediamo con la successiva presentazione.